On our foot, the toes and the metatarsals are concave on the plantar surface of the foot. So the IP, the interphalangeal joints, and the MT joints, the metatarsal phalangeal joints, they sit at a 10 to 15 degree angle toward the IR when the foot is placed flat on the IR. So we have to think about that when we choose our angulation of our tube, because what we're trying to do with our central ray placement is turn and angle the central ray so that the X-ray beam goes through the joint spaces without crisscrossing the bones. So if we took a perpendicular central ray, what would happen is that we would hit bone and be projecting bone into those joint spaces. We would be hitting the bone and projecting it into the joint spaces. But if we angle the tube, as I have here with the blue lines, you can see with the blue lines, we can actually go back and see that they're going directly through the angle of the joint spaces. So when we look at our image, those joint spaces will appear nice and open with no superimposition of the bases or the heads of the phalanges or metatarsals superimposing into the joint space. So this is an image of the positioning for the AP toes, where you can see in the picture of the patient in position, they've shown the angulation of the tube. They refer to it as a posterior angle because it's going toward the posterior side of the foot. And then I've input a picture here showing you the joint spaces, the angle of the joints, and I just continued that central ray from, the picture of the person's foot into the picture of the bones of the foot, where we can see that that central ray is going to slide right through those joint spaces on that patient's foot. So that is the purpose of the angulation of the tube for the AP toes. In this picture, we see a foot that has been placed on a 15-degree wedge, positioning wedge. So they've taken the foot and taken the foot 15 degrees, the plantar surface of the foot, 15 degrees away from the plane of the IR. Now we're placing those phalanges parallel to the IR, and the joint spaces will now be perpendicular to the IR. So since the joint spaces are perpendicular to the IR and we want the center ray to slide right through those joint spaces, it only makes sense that now we can use a perpendicular center ray to slide straight through those perpendicular joint spaces. Okay, now we're ready to look at the anatomy and how it is supposed to look on our images. So in our, we talked about this with the fingers, where we look for the concavity on either side of the phalanx to be equal. Equal concavity on both sides of the phalanx. We're looking for equal soft tissue margins around the phalanx. We're looking for open joint spaces on the phalanx. Metatarsal phalangeal joints. We're looking to see at least half of that metatarsal, at least one half of it. All right. So we have the distal phalanx, the middle phalanx, and the proximal phalanx. We have a distal interphalangeal joint and a proximal interphalangeal joint, and this joint here is the metatarsophalangeal joint. We want no overlap of the tissues, right? If we start seeing, say, the tissue of this toe superimposing into the tissue of the toe that's of interest, that means that the foot was rotated. If we see the concavities on either side are unequal, or the soft tissue margins on either side of that phalanx of interest, then that would mean that there is rotation of the body part. If the joints are closed, that means that either the foot was not raised the 15 degrees so that the phalanx would be parallel to the IR and the joints perpendicular to the IR, or that they did the x-ray with the foot plantar flexed, the plantar surface lying on the IR, and they forgot to do the 15-degree posterior angle on the tube to go through those joints. On the toes, we have to think about the direction of the rotation. We want to rotate the foot so that the toe of interest will be closest to the IR. So if we are taking images of digits 1, 2, or 3, we will be medially rotating the foot to place those digits closer to the IR. If we are taking an x-ray of digits 4 or 5, we will be turning the foot laterally to put those digits as close to the IR as we can. The rotation of the toes is 30 to 45 degrees. You can use the top of the nail bed, the toenail, to kind of measure or visualize that rotation, and the angle that the nail bed is making with the IR will be a good indication of the amount of rotation that you've used for the toe. The central ray for the oblique toes is a perpendicular central ray because we're turning the foot now and we're not working against that longitudinal arch that is what caused the angulation of the joints away from the IR when the plantar surface of the foot was parallel to the IR. Now we're tilting the foot up, angling it away from the IR, and we're not working against that longitudinal arch of the foot. So we can use a perpendicular central ray for our oblique toes. Looking at oblique toes is very similar to looking at oblique fingers. So what the toe we're looking at here is the first digit. So we are seeing the metatarsal. This is the metatarsal here, all right? And then we have the two phalanx here. So a distal and a proximal phalanx, one interphalangeal joint, the interphalangeal joints. It's just the first digit, okay? We have the interphalangeal joint there, and then this one would be our metatarsophalangeal joint, MTP. Okay, and then that would be that metatarsal. We need to see at least 1/2 of that metatarsal, right? So we can put 1/2 right on top of it there. All right, now, once again, it's 30 to 45 degree rotation. So in order to identify that the toes were rotated enough, we'll go to looking for that concavity to be on the plantar surface of the toe. You'll see more soft tissue margin on the plantar surface of the toe. So, this being the big toe, it's kind of easy to see. You can see all of this soft tissue here, all the way out to here. And here on this one, you can literally see that person's nail bed. You can see their little nail bed there, and then the soft tissue kind of comes out around it. All right, so that's telling me that they have rotated it that 45 degrees, that it needs to be rotated. Also, the concavity that I can see here on the plantar surface of that phalanx, more so than on the dorsal surface. See, the dorsal surface looks a little bit more straight. It's not as concave as that that plantar surface. All right, we see the sesamoids kind of peeking out down here. All right, see a little bit of the sesamoids happening. So you'll be able to see the sesamoids a little bit turned out because the toe has been rotated. Open joint spaces in this case, since we are placing the part on the IR, we have to make sure that the part stays parallel to the IR so that those interphalangeal joints and metatarsophalangeal joints will be perpendicular to the IR so that we can use a perpendicular central ray to slide right through those joint spaces and demonstrate them open with no superimposition by bone. So on these obliques, we definitely need to make sure that the part itself is parallel to the IR. Even while we're doing that rotation, we're still looking for the part to be placed parallel with the IR. So we don't want them, pulling their toes up, like pointing their toes up. We don't want them scrunching their toes down onto the board while they're positioning. You may have to kind of, touch your patient's foot a little bit maybe and ask them to relax their toes, into more relaxed position so that you can get them into place nicely. Okay, so for our lateral toes, we need to think, we're back to that thought process of, is this a medial lateral or a lateral medial projection? So in the case of digits 1, 2, and 3, we will medially rotate the foot and use a lateral medial projection of the beam for digits 1, 2, and 3. That's to place them as close to the IR as we can get them, and to avoid OID as much as possible so that we can get the best detail on our image. When we do our 4th and 5th digit, we will rotate the foot so that the lateral side of the foot will be touching the IR, because the 4th and the 5th digit are on the lateral side of our foot. And then the beam would be entering the medial side of the toes and exiting the lateral side of the toes. So the 4th and 5th digit would be a medial lateral projection. Digits 1, 2, and 3, a lateral medial projection. Digits 4 and 5, a medial lateral projection. This is an example of the 4th digit with a medial lateral projection. This being remember, the big toe is more medial, right? So the big toe, the 1st digit is medial. So the side of the toe, whatever toe we're talking about that's closest to the big toe, is the medial side. So this would be a medial lateral projection of a lateral position of the 4th digit. Okay, so the criteria on a lateral toe is the exact same criteria that we use for a lateral finger. So we talked about concavity on the plantar surface of the phalanx, more concave on the plantar surface, and more convex on the dorsal surface of these toes. That would indicate a true lateral with no rotation. Central ray, once again, is perpendicular. The body part needs to be placed parallel to the IR so that the interphalangeal joints will be perpendicular to the IR. Therefore, we can use a perpendicular center ray to go straight through those joint spaces and project them open on our image, which we see here. They're very nice and open, these joint spaces. Even the metatarsal phalangeal joint, all right? And then remember, we still have to see half of that metatarsal there, all right? So we have distal phalanx, middle phalanx, proximal phalanx, and then the metatarsal there. All right, and then we'll look to, make sure that we have more soft tissue margin on the plantar surface, right? We'll see more soft tissue on the plantar surface. Okay, let's do a little bit of anatomy on our on the bone here. Number 1 here is that's the talus. Number 2, from here to here, is calcaneus. Number 3 is the navicular, which articulates with the talus. Number 4 is the cuboid, which articulates with the calcaneus. And then we have cuneiforms 1, 2, and 3 that articulate with the metatarsals. We have the tuberosity at the base of the 5th metatarsal. And then we have our distal and proximal phalanx of the 1st digit, and then the metatarsal. Then we have the distal phalanx, middle phalanx, proximal phalanx, and then metatarsal of 2 through 5, digits 2 through 5. So over here, right, distal proximal metatarsophalangeal joint there of the first digit, and then this is a metatarsal. Right, then we can follow that first metatarsal to the first cuneiform. Then we've got the second and the third cuneiforms, which is kind of superimpose here, the third and the cuboid superimpose, because now this part here is all cuboid, and it's a little superimposed with that third cuneiform. This part here that's articulating with the talus here is the navicular bone, right? This one here is the navicular bone. And then this is part of the calcaneus here coming up toward that cuboid. And the calcaneus will articulate with the cuboid. This part here is what we're seeing here, right? Number 4 is here. Trying to put it together there. 1, 2, and 3, right? We've got that calcaneus, I'm sorry, not calcaneus, the navicular there. I just wanted to erase that out, okay? All right, so hope this was helpful. Also, let me take this off really quick, and let's look at the malleoli. This is the tibia, all right? This is the medial side of the foot. Remember, our big toe is the medial side of our foot, right? So the tibia is on the medial side, and then the fibula is on the lateral side. So in our x-rays, we'll see at least 1 inch of the tib fib, right? So we'll be able to see that medial malleolus and the lateral malleolus on our foot x-rays. So once again, we have to talk about that longitudinal arch and how it's shifting the metatarsals and the phalanges up away from the IR that we would be placing it on, right? So that arch brings part of the plantar surface away from the IR, putting those metatarsals and phalanges at an angle. That means the joints that we're trying to go through are also at an angle. So in order to go through those joint spaces, we have to angle the tube posteriorly. They call it posteriorly because we're angling posteriorly towards the posterior of the foot. All right. So that is the purpose of this angle that we're seeing on the tube that they put here. Right? They put that angle on the tube to show you. Now they describe this as being perpendicular to the metatarsals. So if I put a line down those metatarsals, you can see how that red line, which is our central ray placement, it hits those metatarsals perpendicular. So the amount of angulation is going to depend on how much that person's foot arches up away from the board. So we're looking at 5 to 10 to 15 degrees, depending on the patient's foot. So you can kind of gauge that by looking at the top of the patient's foot and trying to visualize the collimator box, the flat surface of the collimator box, making that flat surface of the collimator box parallel to the top of the patient's foot. So, like you got the collimator box here, like that. Try to kind of visualize that flat surface of the collimator box being in line parallel with the top of the patient's foot. And that's like a visual way that you can just kind of judge how much you may need to angle more or less for, whatever patient you're doing. Okay, so the positioning of the AP foot, we need to see at least 1 inch of the distal tib fib. To know that the patient's foot was not rotated, we will look at the base of the 2nd through 5th metatarsals, and we'll be able to see superimposition at the bases, not the head. The head is the more distal part. The base is the more proximal part. All right. So the bases of the metatarsals will be superimposed, and we'll have equal distance between the metatarsals here, between the shaft of the metatarsals. That tells us that we did not rotate the foot. It needs to be a straight AP foot with no rotation. All right, we can identify the medial malleolus and the lateral malleolus, the medial of the tibia, the lateral of the fibula. All right. Okay, and then sufficient angulation is demonstrated by those joint spaces being clearly demonstrated open. That lets us know that the tech did indeed angle the tube, and that the central ray went through those joint spaces without projecting bone into the joint space and superimposing them. The oblique foot requires 30 to 45 degree medial rotation. The rotation is dependent on the patient's foot. Here they've used a 45-degree sponge and placed the plantar surface along the 45 degree of that sponge to measure to make sure that they are rotating them in a 45 degree. At 45 degrees is midway between the AP position and the lateral position. So that's another way that you can gauge your rotation when you're turning the foot for the rotation. But you can, if you have sponges available, you can use the sponge like they did here to make sure that you get the 45. 45 is for an average foot. So 45 is usually what we would use for the rotation. The central ray will be perpendicular because once again, now we're rotating the foot. We are not working against the longitudinal arch of the foot anymore because we're obliquing the foot halfway from AP to lateral. Okay, so now on the oblique foot, to describe the correct amount of rotation or sufficient rotation was used when we positioned the patient, we will look for the base of the fifth metatarsal, the tuberosity at the base of the fifth metatarsal should be shown in profile. We will be looking to see the intertarsal spaces all the way around the cuboid. The cuboid will be free of superimposition of that third cuneiform, which was a problem in the AP foot x-ray, right? We will be turning the calcaneus out. We'll be able to see the calcaneus more. And we'll be able to see the distance between the third through the fifth. So between the third and the fourth and the fifth, we'll have more separation between those metatarsals at the base of the metatarsals than we did in that AP. Remember in the AP, we were saying that the bases of those metatarsals 2 through 5 are going to superimpose. But now we'll be able to open up the space between the third and the fifth more so. And then what we notice is that the first and second, the base of the first and the second are going to superimpose even more so than they did in the AP. So we're going to have more superimposition here between the first and the second, the base of the first and the second metatarsals. Sinus tarsi, let's look for that little guy. There's the sinus tarsi right in this area here, right? We'll be able to see a little sinus tarsi. That wasn't, the color's a little light. Let me change it. Right in this area here, little sinus tarsi, right? So that's that little area between where the talus and the calcaneus articulate together. There's the calcaneal sulcus that runs between, and that kind of helps to create that little sinus tarsi. Also in this image, we can see the navicular nice and pretty. Got the navicular here, very well demonstrated, right, where it articulates there at the talus. Here, that's the talus, and this is the calcaneus. All right, and then of course, at least an inch of the distal tib fib. On lateral foot positioning, we want to ask the patient to dorsiflex the foot as much as they can. That means bringing the toes closer to the tib fib, pointing the toes up towards the tib fib. That will be decreasing the angle between the tib fib and the toes. And then we'll palpate the plantar surface of the foot and make sure that the plantar surface of the foot is placed perpendicular to the IR to place that foot in a true lateral position. Notice there's a sponge over here underneath the patient's knee, because if we let her relax her knee all the way down, that more of the dorsal surface of the foot will start to make contact with the IR, and the plantar surface of the foot will be turned up and facing the tube more. So we usually will have to put a cushion underneath their knee to help them hold that true lateral position of the foot. Okay, so for the routine foot positions, we're going to do a medial lateral projection. That means the lateral side of the foot is going to be rotated out and laying down on the IR. The sensor ray is going to enter the medial side of the foot. We want to see at least 1 inch of the distal tib fib here. And we also want to see the fibula superimposing the posterior half of the tibia here. So we can see that it's a little opaque line if you look very closely. There's a little line there, little opaque line going across there that you can see that's where the fibula is superimposing over the tibia right there. Okay, and then also we will say we're going to describe the calcaneus as being in profile. Calcaneus in profile. We will be able to see the 5th metatarsal more inferior than the other metatarsals, but we will describe the metatarsals as being superimposed for a true lateral positioning, just keeping in mind that natural transverse arch will make that 5th metatarsal a little bit lower, and we'll be able to see it not, completely superimposed with, 1 through 4. So that's the 5th metatarsal that's down low here, and then the base of the 5th. We are going to be able to see the subtalar joint, which is this area in here, the subtalar joint right in here, or also known as the talocalcaneal joint. We can see where the calcaneus articulates with the navicular here. Be able to see that navicular nice and pretty. All right. So I think when we talk about this one, saying that it's parallel to the IR, right? We want from the calcaneus to the tips of the toes, we want that foot parallel to the IR. Otherwise, we're going to end up with foreshortening of the metatarsals, right? And we don't want to do that. We don't want any foreshortening of the metatarsals. We don't want the calcaneus to be distorted. We want to see it in profile, right? So if the foot is tilted away from the IR and not parallel, we're going to start seeing some distortion on the calcaneus. Rotation, we will be looking for that tib fib. Where is the tib fib, right? And the metatarsals, right? If we start to say that the metatarsals are separated and not superimposed, that means that they're not in a true lateral, that they're rotated. If the fibula is superimposed over the anterior part of the tibia, then we have a rotational issue because the fibula is supposed to be superimposed over the posterior part of the tibia. So those are ways that we would be able to recognize and identify a rotational error that needed to be fixed. March fractures are a type of stress fracture. Stress fractures are caused by constant weight bearing on the bone, and it can cause small fractures in the bone. So you can have stress fractures throughout any of our weight-bearing bones throughout the body, but the March's fracture are common in people that are in the military, or or even athletes, people that put a lot of stress on their feet, and they're up on their feet, maybe jumping and putting a lot of stress there on those bones. So the black arrow is showing us the area of where the fracture was. And as you see in B and C, this is where the bone is rebuilding itself around the area of that stress fracture. So you can kind of see that gradual, building of bone around that small, tiny little fracture where it kind of ended up just, like deforming the bone a little bit. But that's just what happens with our bones. They kind of overreact and overbuild. But what I want you to know about that one is that it's called a March fracture. It's caused by, it's a stress type fracture caused by weight bearing, constant jumping, constant stress on the bones that are bearing the weight of the body. This is an example of a trauma positioning of the foot. This not necessarily is always a trauma though. I mean, I've done a lot of foot x-rays like this where the patient was in the bed and unable to bear weight on their foot, or maybe they just, were someone who is unable to walk and wheelchair bound or bedridden. And you have to kind of get a little fancy with your positioning of the equipment. So this is another example of where we're bringing the equipment to the body part to try to make the recipe happen, right? Our central ray recipe and our plantar surface of the foot placed on the IR. That's part of our recipe of positioning an AP foot. Central ray is going to be perpendicular to the IR for the trauma positioning, this type of positioning of the foot. There's a lot more plantar flexion of the foot happening in this position because the leg is laid out straight. So we'll be placing the central ray perpendicular to the IR so that we can decrease any amount of distortion that angling across the IR may cause. And the central ray is still at the metatarsophalangeal joint. Now, the positioning of the toes is the same, the AP toe positioning for trauma. That one also would be, keeping the central ray perpendicular to the IR, placing the IR along the long axis of the foot against the plantar surface of the foot. Now, for the trauma oblique foot of a patient who is unable to turn and oblique their foot for us, we have to use the tube angle. So remember my rule. If you can't put the body part where you need it, then you angle the tube to project that body part where you want it to be on your x-ray. So our angulation would be 30 to 40 degrees cross-angled. They describe it as cross-angling because we're going across the foot transversely with the direction of the beam. We're not going along the long axis of the foot. We're going across transversely across the foot. So they call it cross-angling. Notice that the central ray enters the more lateral side of the foot here, and it's going to exit the more medial side of the foot here. Therefore, it gets the name of a lateral medial projection. So I just want to make sure that you understand why we call it a lateral medial projection, although it is not a lateral position. This is an adaptation of an oblique foot position because it is in a trauma situation. Patient cannot rotate the foot. We cross angle. We enter a more lateral side of the foot, exiting the medial side of the foot to ensure that we're projecting the entire foot and all of the metatarsals and all of the bones that we need onto our image receptor. Now for our cross table laterals with a horizontal beam, you'll do a lot of these in trauma, of all the whole leg, the foot, the ankle, the tib fib, the knee, all the way, all the way to knee, and then also distal femur as well. So you'll be doing these cross table horizontal beam projection laterals. So what's important to notice here on this picture is that they've raised the foot on this sponge, all right? The reason for that is because we need to make sure that we do not clip the bottom of the foot off of the IR. So we're going to raise the part of interest higher than the bottom edge of the IR. So that way the divergence of the beam, we can get that part as centered on the IR as possible in the situation that we have, but at the same time making sure that the part is higher than the lower edge of the IR to make sure that we don't clip any anatomy. The center ray is still the same at the metatarsals. Notice that this is a lateral medial projection because there's their pinky toe. All right, so we're their little pinky toe there. Right, so we're entering on the pinky toe side, exiting on the big toe side here. So that is a lateral medial projection, cross table, trauma, foot. The following three positions that we're going to look at now are special optional images of the foot. They are not routines. So if you have a person that comes in with a prescription that says right foot, you will not be doing these unless they are ordered specifically as an extra order added onto the routine positions. Okay, so this first image is the AP weight-bearing foot, and this is the lateral weight-bearing foot. On the AP, notice there is an angle on the tube. It is a 15-degree posterior angle of the tube. Because why? Because we're working against that longitudinal arch of the foot. We're trying to go through those joint spaces. This AP weight bearing is a bilateral projection, meaning that we'll have both the right and the left feet on the x-ray. The lateral weight bearing is going to be a unilateral. We can only do one at a time. So we'll do, one. Now this is a horizontal beam, perpendicular central ray. Central rays are still at the base of the metatarsals. So on the AP weight bearing bilateral of the feet, notice that we say right here the entire foot is not going to be demonstrated. Right, that's just the nature of where the central ray is and the fact that the legs, the tib fib is in the way when the patient's standing up. So we won't be able to see all of the calcaneus. We'll be able to see part of the talus here anteriorly where it articulates with the navicular, but we won't be able to see the calcaneus, all of the calcaneus. All right, but we definitely want to be able to see all of the toes there. And for rotational problems, I mean, usually you wouldn't have much of a rotation problem with a weight bearing because they're going to stand flat on their feet the way that they naturally stand. So usually that wouldn't be a problem. But we'll want to be able to see the joint spaces to identify that we remember to angle the tube. So tube angulation is all about those open joint spaces. Still just like we did with the regular AP foot, they mentioned that we can see the distance or the the spaces between the first and the second cuneiform. So that's something, a little fun fact here that they wanted us to remember, and that's a way to identify that the patient was, standing straight without rotation. That's something that would show us if they were rotating their foot, kind of like rolling out on the lateral side of their foot, or maybe maybe their knees, maybe this person naturally either they're bow-legged or their knees go inward. I'm sure you know what I mean when I talk about, some people, how their knees will naturally go outward more and some people's knees will go inward more. Those are things that you're going to be recognizing on your patient as you're doing their x-rays. And you'll know that it's not an error on the image, but it's just the way that they naturally are. If it is such that that it's actually distorting the anatomy from the way that it needs to look, so say that their knees do rotate inward, and then we're getting maybe their knees go inward so that that second cuneiform is going to superimpose the first cuneiform, but you would know that by seeing your patient, and then you could even note that, that's a note that you could put, so just, that, usually you wouldn't have any problems with that really though, because they're just going to stand in their natural form, and you don't want to change that because the doctor is going to assess that natural, curve and arch of the transverse arch that's happening on that patient when they stand. So they kind of really want to see that. They want to see any type of abnormalities that occur when they're just standing straight up. I mean, that's basically the whole purpose of that exam. On the lateral, we are looking for the longitudinal arch. So remember, the AP is for the transverse arch, the lateral is for the longitudinal arch. And the lateral, the criteria is exactly the same as a lateral foot. Okay, the alternate lateral medial foot is when the patient condition is so that you can't place the lateral side of their foot on the IR and do the medial lateral projection. It will still give you the same x-ray as a lateral foot x-ray with a medial lateral projection. It will be the same exact x-ray with the same exact criteria. The only change is that maybe your patient could not rotate their leg out and you had to do it in this, with the lateral medial projection instead of the medial lateral. The central ray is the same. The criteria of the images are exactly the same. The book mentions that it's easier to get the foot in a true lateral position this way, but the disadvantage of doing it this way is that it's less comfortable for the patient. The advantage to doing it this way is that it will put the foot more easily into a lateral position. All right, so this is an alternate oblique position. We're going to rotate, instead of on our routine position, we rotate medially, taking the big toe and rotating it towards the IR. And we're going to create some nice separation between those metatarsals 2, 3, 4, and 5. In this case, we're going to rotate the foot in a lateral rotation, bringing the big toe up away from the IR and creating space between the first and the second metatarsals. And we'll be seeing these structures on the medial side of the foot. We'll see separation between the first and second cuneiforms. We'll see that navicular, nice and pretty. All right, but then we superimpose metatarsals 2, 3, 4, and 5. So the whole reason for this is to see navicular, the first cuneiform free of superimposition, and the space between the first and the second metatarsals. Okay, so the sesamoid bones of the foot are embedded in tendons, and they act as like a pulley system for those tendons to allow elevation of the big toe. So we're going to look at two different ways of doing the sesamoid bone positions for the foot. Okay, all right, so this is the two positions for the sesamoid bones. The first one is the prone, and the second one is the supine. All right, so with the prone, I want you to notice that the sesamoids are going to be much closer to the IR than they are with the supine position. So we could say that the prone, because there's less OID, this would give us more detail and be a more diagnostic image than the supine position, which puts the sesamoid bones way far away from the IR, creating OID. It's creating magnification and penumbra of those little bones that we need a lot of detail to see. So if your patient can lie prone and stretch their toes out like this, that's the best way to do the position. Notice they're very specific about the dorsiflexion of the foot. They say dorsiflex the foot so that the plantar surface of the foot forms a 15 to 20 degree angle from vertical. Vertical would be, if you watch the center ray is perpendicular. That would be a vertical line. That center ray, if we just continue that center ray on, that's vertical. So we're talking about the foot, the plantar surface of the foot being 15 degrees from that vertical line. Down here, it's the angle is being made here. Okay, so 15 degrees from vertical. We're going to flex the foot, dorsiflex the foot, dorsiflexing the foot. So the plantar surface of the foot is 15 to 20 degrees from a vertical line. Okay. Now I want you to note that the sesamoid position is considered a tangential X-ray beam. because it's going to skim the ball of the foot. So remember, a tangential beam, a tangential projection is going to skim a rounded body part, and that's exactly what we're doing here. Now on this image, the book will tell us that I think it says that we need at least the first 3 metatarsals, 1, 2, and 3. This one shows all of them. This is just such a nice image and demonstrates those sesamoids so nicely that I had to show it to you. It looks like this sesamoid may have a little bit of abnormality here, maybe a little fracturing here. This one looks intact, but then again, I'm not a radiologist, so. But we have some, we can see the sesamoids very clearly here, very clearly without superimposition of the metatarsal there, right? Beautiful. So we can find the first digit and then find those sesamoids there without superimposition of those metatarsals. Now, if the patient is not dorsiflexed enough, what's going to happen is this metatarsal here will superimpose those sesamoids, and we got to stretch those toes back to let those little sesamoid bones stick out so that we can see them without superimposition of the metatarsal. So it's a very important part of that positioning. So anyway, so just so you know what we're looking at these little sesamoid bones here, these 2 little guys here. We need to include at least the 1st through 3rd metatarsals, and then of course the sesamoids. Looks like a little frog. It looks like a little frog. Okay, all right, so that's it for that one. So for calcaneus positioning, we're going to look at two different ways to do the axial positioning. You're going to only do one, so you'll find out which one that you prefer, the way that you prefer to do it, and then you'll always do it that way, or your patient condition will determine how you can do it. So and then we'll also look at a lateral calcaneus. So our basic routine calcaneus is just a plantar-dorsal or dorsal plantar, just one axial image and one lateral image. So this is a planto-dorsal axial calcaneus. This is the way that I always did my calcaneus. I always did the planto-dorsal, where the patient would sit on the table for me, put their leg all the way out, place their foot on the IR, and I would have them stretch their foot back. Here you can see they've placed some tape around the foot, and then the patient themselves can pull their foot back for you so that we don't have those metatarsals superimposing, or the digits actually for that matter, the digits or the metatarsals superimposing into that talocalcaneal joint, which is what we're looking for. So we are very specific about the flexion of the foot, that it's a 90-degree flexion of the foot. We want that plantar surface of the foot making a 90-degree angle to the IR. So they say that the foot is perpendicular to the IR with a 90-degree flexion of the foot. We could say the plantar surface is perpendicular to the IR as well. If the patient is unable to dorsiflex their foot enough, and it looks more like their foot is kind of, and of course I'll probably exaggerate it a little bit just to get the point across, but if instead of their toes pointing up straight, maybe their foot's like this, now what do we got to do? We got to change the angle of the beam. We're going to increase the angle of the beam so that we don't project those metatarsals into the joint space. All right, so we just got to we'll just have to switch it up depending on what our patient can or can't do. Now, the normal positioning is with their foot dorsiflexed to 90 degrees from the IR. Then we use a 40-degree cephalad angle along the long axis of the foot. Cephalad because, it's kind of going towards their head, right? It's definitely not going down towards the heel. It's going towards the head in that direction, if it continues on in that direction. So they consider it a cephalad angulation along the long axis of the foot. Center raise at the base of the 3rd metatarsal. To emerge means it's going to exit near the posterior malleoli. posterior to the malleoli, which those malleoli are here, right? So if that beam continues on, it's going to exit posterior to that malleoli. These are two images demonstrating the dorsoplantar projection, calcaneus. Either way, whether you do plantodorsal or dorsoplantar, you still want the same exact x-ray. You're not going to do both of these. You'll do one or the other. When you do the routine, you'll only be doing two x-rays. You'll do one axial and one lateral. All right, so but this is just two other ways that we can do it. These are both the dorsoplantar projection because it's entering the dorsal side of the foot, exiting the plantar side of the foot. So on this one, again, 40 degree angle to the long axis of the foot. And this picture is showing 25 degrees here. That's just the degrees of the leg. The lower leg has to be angled a little bit anteriorly so that it won't superimpose the calcaneus for the x-ray. So that's why they showed this little angle here. So I don't want that to confuse you. That's just about the patient leaning forward, leaning that tib fib forward so it won't superimpose the calcaneus. So don't worry about that. You do need to know about that central ray angulation, all right? Oh, I put a note here, I didn't notice. Standing, the low leg is angled anteriorly 25 degrees to avoid superimposition, right? Superimposition of the lower leg on the calcaneus. So let's look at some anatomy of the calcaneus before we look at the x-ray of the calcaneus. We want to be able to identify those facets. Now this, I took this picture from Ken Hub because this picture also shows the facet for the cuboid. So remember how we've been identifying the calcaneus and then that cuboid, where the cuboid articulates with the calcaneus. So this would be the cuboid here articulating at the facet for the cuboid, where this image did not show the facet for the cuboid. So I wanted to show you this one right next to it so that you would know that that facet is there. And if you ever see a picture with that anterior, that facet for the cuboid, you don't confuse it with the anterior facet, which is here. This is the anterior facet, right? This is the middle facet, and this is the posterior facet. This is the facet for the cuboid, this facet you're seeing right here. All right, so I just wanted to show you that so you wouldn't get confused, because I sure did. So I want to make sure that you don't get confused like I did. All right, and then this little green area that they've shaded in here for us, that's that calcaneal sulcus I keep talking about. That's that calcaneal sulcus that helps to form that sinus tarsi where the talus sits on the calcaneus. This is a very nice view of the calcaneus, but it does have some quantum model. So I'm pretty sure that as soon as you saw it, you could recognize that graininess in the image up here. But this is not the area of interest. It is quite modeled. But down here at the calcaneus, I can see the trabecular markings, those lines going through that spongy bone. Those trabecular markings are showing very nicely. The calcaneus is shown without any elongation, without foreshortening. Very important structures to be able to find is the sustentaculum tali of the calcaneus here, right? That sticks out medially. That's how you can identify the medial side of the foot is the sustentaculum tali. And then on the lateral side of the foot, we have the trochlea. It's called the trochlea or the perineal trochlea. All right, those two structures are important to us because those little structures are going to tell us about our rotation. So those little structures are telling us that the foot was placed vertical, that it's not rotated, because I'm going to show you some that are rotated here in a minute, and you can clearly see that the sustentaculum tali and the trochlea are not in profile. So it tells us over here the perineal trochlea, also known as trochlear process. needs to be in profile. That's this little guy right there, right? The sustentaculum tali, the first one I mentioned, which is the first one I went to, I guess that's why I mentioned it first, because it's always the first thing I look for. Sustentaculum tali, right there, in profile, right? So that tells us that the foot was placed properly with no rotation of the foot. Another thing we can look for is those little medial and lateral processes. That's 4 and 2 down here. 4 is the lateral process, 2 is the medial process, because remember the sustentaculum tali is on the medial side of the foot. Another way to know where the medial side or lateral side of the foot is number 7 here, which is the base of the tuberosity of the 5th metatarsal, right? We know the 5th metatarsals are pinky toe, and that is on the lateral side of our foot. So ways to identify the medial and lateral side of the foot. Now, the star of the show is the talocalcaneal joint, which they've labeled as number 8 here for us. And you can kind of see that little grayish area right in here. And then because of the way that you see if you go back and look at the facets and the way that talus sits on top of the calcaneus, it's not a straight joint the way I drew it here. It really isn't. I'm going to erase that because we're going to follow the true joint, and it kind of makes this little dip upwards like this. Kind of like a little, I always call it a lightning bolt. Looks like kind of like a little lightning bolt there. All right, so that's the talocalcaneal joint that we're looking for to be open, free of superimposition of those metatarsals. We don't want to project those metatarsals into the talocalcaneal joint. This really is the star of the show. The other structures we were looking at, yes, they need to be included. Yes, they need to be demonstrated exactly the way we've described it here with criteria. But the main star of the show is that talocalcaneal joint. All right. These other structures we can reference for proper positioning of the foot and proper angulation of the tube. The proper angulation of the tube really is about that joint space being open though too, right? As most of our x-rays, right? That angle of the tube is always about going through those joint spaces and then not elongating that calcaneus. Okay, so let's look at some errors in the calcaneus image. Now, I wouldn't say that this is a really bad image. I would say it's a slightly rotated image where we can see the 5th metatarsal and the 4th metatarsal out laterally. So that tells us that they rotated the foot a little bit laterally. And then they would need to fix that rotation. But we can see the joint. We can see the joint space. So that talocalcaneal joint space is clearly demonstrated. But because of that rotation, let me erase this off because I want you to be able to really hone in on this sustentaculum tali. It's all right. It's not too bad. I mean, it's still there, right? It's still in profile. Not as pretty as the last one, but it is, we can see it in profile, right? But that rotation is kind of taking away from the diagnostic quality of those lateral and medial structures that we're looking for on that calcaneus. So, yes, the angulation was good, and yes, the joint is beautifully opened, but it is slightly rotated laterally. So we should internally rotate the leg and take another image if necessary. Now this one shows even more lateral rotation because now we're seeing 3, 4, and 5 rotated out laterally. All right, that's the metatarsals of the digits. Also, this one is hyper dorsiflexed, if that's even a word, right? They've dorsiflexed the foot too far, and now we've got some superimposition on the talocalcaneal joint that should be open. Right, so they've brought the foot up and dorsiflexed it too far, and we're kind of seeing, parts of the tib fib there in the way. So this one definitely what we need to do is relax the dorsiflexion of the foot so the plantar surface is perpendicular to the IR, right? Bring it dorsiflexing the foot so it's vertical, and then double checking our angulation that we're only angling 40 degrees. So just checking that angulation and the proper position of the foot. And we have to internally rotate the foot to take away that rotation, because we're also, that sustentaculum tali is being superimposed, and it's not in profile anymore, along with being superimposed. It's not in profile either. And the trochlea too, right? That trochlear process is not really being seen very clearly either. Even the medial and the lateral processes are not clearly demonstrated here. So quite a few issues to deal with on that specific x-ray for repeating it. Now this one is showing elongation and complete obliteration of the talocalcaneal joint, and metatarsals being completely projected down into the areas of interest. So, these lines we're seeing here are actually metatarsals being projected into that down near that talocalcaneal joint, what we want to see. An elongation of the calcaneus. It looks long and skinny. So the central ray was placed too high, projecting those metatarsals down over the area of interest, which is the talocalcaneal joint. So this one definitely would be a repeat. It is definitely not diagnostic at all. The talocalcaneal joint is not clearly demonstrated in this position. Okay. All right, so for the lateral calcaneus, our central ray is going to be just inferior the medial malleolus. So again, it's a medial lateral projection. And notice the collimation is right around that calcaneus. So once again, this is the anatomy of the calcaneus from a lateral view. All right, seeing it from the medial side and from the lateral side. Remember, the lateral side, if we're looking at the perineal trochlea, we're looking at the lateral side of the calcaneus. If we're seeing the sustentaculum tali, this guy right here, we're looking at the medial side of the calcaneus. Remember, this facet for the cuboid anteriorly, right? Then the anterior facet, middle facet, posterior facet. All right, so remember your facets: anterior, middle, and posterior facets. And then that facet for the cuboid is projecting anteriorly from the calcaneus. Calcaneal tuberosity, posteriorly, right? The process, you can see the process sticking out here. So this is what we want to see on our lateral calcaneus. So it's going to sound very similar to our lateral foot, and that we won't be talking about metatarsals because they're collimated off. But we can say that the calcaneus is in profile. We can say that talocalcaneal joint needs to be clearly demonstrated, right? That's a big deal. The talocalcaneal joint, and then also that sinus tarsi. Sorry about that. I wanted to get this better. Sinus tarsi right here in this area, that talocalcaneal joint. All right. And then remember the dome of the talus, that tibiotalar joint there. And then once again, we're going to talk about that fibula superimposing the posterior half of the tibia there, right? So we got the lateral malleolus of the fibula that's superimposing the posterior half of the tibia. All of those things, so that definitely is about rotation, right? No rotation demonstrated by the fibula superimposing the posterior half of the tibia, right? The talocalcaneal joint visualized and demonstrated, the calcaneus in profile. We can see the cuboid where it's articulating at the calcaneus there. We can see the navicular beautifully where it's articulating at the talus here. All right, so all of those things are going to tell us proper positioning of the foot with no rotation, with the foot parallel to the IR. So no foreshortening of the calcaneus lets us know that the calcaneus was placed parallel to the IR. The open talocalcaneal joint tells us that it was placed parallel to the IR with no rotation. The dome of the talus tells us that it was placed parallel to the IR with no rotation. The tib fib definitely is all about rotation. Nothing about the parallel placement, but about rotation, because we're talking about anterior posterior superimposition there. Okay, so we looked at the sinus. Okay, the sinus tarsi there. Okay. Yeah. Okay, so calcaneus in profile. We looked at the cuboid. Looked at the navicular, the talus there, subtalar joint, the tibiotalar joint or talar dome, and then the fibula is that yellow squiggly lines there, all that yellow there that I put right here is that fibula superimposing the posterior half of the tibia. Okay, so I want to make this clear. The ankle routine. You usually will only do 3 images of the ankle, whether you're going to do a Mortise view or a 45-degree oblique of the ankle, the number 2 and 3. That's going to depend on protocol, where you are working, or the site where you're doing your clinical rotations. So when you do an ankle, make sure that you ask them before you do your first ankle, or when you watch them do their first ankle, make sure that you clarify, are they doing a Mortise ankle or are they doing the 45-degree oblique ankle, because they are going to look different and you need to know the protocol where you are. All right, so now when we start looking at these images of the ankle, we can see what we've been talking about with the superimposition of the tib fib, because we can see the tibia here and then the fibula here, right? So we can see how that fibula is superimposed over the posterior half of the tibia, even in this picture. Even though it's not an x-ray, we can see that it's definitely on, superimposing. We can't see the rest of the tibia because the fibula sits on the posterior half, of the tibia in the picture itself. So remembering that the lateral malleolus of the fibula is a half an inch posterior to the tibia, and the lateral malleolus of the fibula is half an inch distal and posterior to the medial malleolus of the tibia. Okay, so it sits a little bit behind and a little bit lower than the tibia. I need you to understand that. But when we think of it in terms of the mid-coronal plane, which is a plane that would cut the leg in half from anterior to posterior, the mid-coronal plane, we could create an angle with what we call the intermalleolar plane or intermalleolar line. It is much like our interepicondylar line, right? So we can measure this intermalleolar line and its relationship from the malleolus of the fibula to the malleolus of the tibia. That line there that can be drawn will actually make a 15-degree angle from the mid-coronal plane of that leg if we slice that leg in half anterior to posterior. Going back to that intermalleolar line, let's think of the IR as we're looking at the leg laying on the IR. Let's imagine the IR being the mid-coronal plane, because that's the way the mid-coronal plane lies along this patient's leg. It would be the mid-coronal plane goes right down the middle of the leg like this. It's a plane that goes down the middle of their leg, such as this entire IR. If we took this entire IR and kind of shoved it up into their leg here, that would be the mid-coronal plane of that leg. So we would be able to measure the line between this lateral malleolus that we see here with the medial malleolus that's on the other side of their leg. And if we drew a line or ran a sword from the lateral malleolus through the medial malleolus, we would see that that sword would be making an angle toward the IR on the malleolar side, the lateral malleolus, the lateral side. So there would be an angle, about a 15-degree angle of that intermalleolar line to the IR in a natural AP position of the ankle. And that's all because the fibula sits more posterior to the tibia. So that's important to understand. The intermalleolar line lies at a 15-degree angle to the midcoronal plane in anatomical position. Therefore, in an AP ankle, the intermalleolar line will lie 15 degrees from the IR. All right, so now ways to identify an AP ankle with no rotation. I'm going to go straight to the Mortise joint. The Mortise joint is the joint that surrounds the talus. So as you can see, the fibula here, that lateral malleolus of the fibula, is superimposing part of the talus, which means it's also superimposing part of the Mortise joint, which is the joint that surrounds the talus. Right, so that is the first thing that you're going to look at on your ankle x-rays to identify whether it's an AP ankle, a Mortise ankle, or an oblique 45-degree angle ankle. This is important, okay? Because we have to be able to identify what's happening at the Mortise joint, and then you'll be able to tell me if this is an AP ankle or not, because you're going to have to identify ankle images. So, and you're going to have to know what your ankle images are supposed to look like when you do it on your patient, right? So we need to have at least 1/3 of the tib fib, right? At least 1/3 of that distal tib fib, about a half of the metatarsals, proximal half of the metatarsals included, and only superior and medial portion of the Mortise joint is open. What do they mean by that? They mean that only the top part, the superior part, and the medial part over here by the medial malleolus of the tibia, right? So only those parts of the joint are open. This point over here where the malleolus is superimposing it is closed. So open Mortise joint here, superiorly and medially. And that's how we identify in words what an AP ankle is supposed to look like. So we need to be able to say it in words, and we also need to be able to recognize it visually by looking at our x-ray. Now, the view to open the Mortise joint requires us to rotate the leg medially, 15 to 20 degrees. In doing this, we will be placing the intermalleolar line parallel to the IR. So if we drew a line from this malleolus to this malleolus, we would end up with a nice parallel line, parallel to the IR. If the patient were in an AP position, this would not be the case. Remember, an AP position would create a 15-degree angle at that intermalleolar line because the leg would be rotated back this way, not that far, but it would be rotated back to vertical, right? The toes would be vertical like this and they would be straight, and then we would end up with that angle between the malleoli. So this is just I think from this view we can kind of imagine that intermalleolar line better, how it would look with an AP position of the foot with the toes sticking straight up, the medial malleolus here, the lateral malleolus back here. That's that 15-degree angle that would be made with the IR. In this case, nope, we're looking at a rotated foot. In this picture, we're actually looking at a foot that's been rotated to place that intermalleolar line parallel. We can see that lateral malleolus. We can see the medial malleolus. We can draw a line straight across them and see how parallel that is with the IR because they rotated the foot that 15 to 20 degrees. So important to understand this positioning. Okay, so this is the ankle joint Mortise view. We can see all of the green shaded area, and I'm going to draw it in just in case you can't see it, or maybe I'll just do the pointer here. I'm going to follow it from the medial malleolus, the MM. If you follow the pointer, all of this, and all of this, all the way around that beautiful talus is open. That is the Mortise joint. That is how we know that this patient's foot was rotated medially 15 to 20 degrees to place the intermalleolar line parallel to the IR, because we are looking at the joints, the entire Mortise joint open. So sufficient rotation demonstrated by the no superimposition of the talus and the Mortise joint open from the medial side, the superior side, and the lateral side of the joint. So the entire 3 parts of the joint space are open. That proves to me that they rotated that patient's foot so that the intermalleolar line was parallel to the IR. And I can identify this as a Mortise view because I can see the open joint space from the medial side of the talus, the top of the talus, and the lateral side of the talus. There's no superimposition of the talus. This is another AP mortise view of the ankle. All right. So once again, they put a little shaded dotted line there where my pointer is, okay, around the talus, showing us that the joint is fully open from the lateral side, superior side, and medial side, all open. All right. So over here, we can say sufficient obliquity right here, the lateral and medial joint space is open. That would be the lateral side and the medial side of the joints are open. That tells us that we rotated them properly, enough to put the intermalleolar line parallel to the IR. And then still the same stuff, 1/3, 1/2 down here, the metatarsals, 1/3 of the tib fib, you know, and then we'll talk about those malleoli being in profile here and here, because we place that intermalleolar line parallel to the IR. So now those malleoli are beautifully in profile for us. All right. And there's minimal, if any, superimposition here at the tib fib. Right. So let me erase this here so we can see it more clearly. Right. So just right in here, they're talking about this area right in here. So if you go back and compare the AP view, remember the AP view, there was superimposition at the tib fib here. So go back and compare the AP with the mortise view side by side and make a comparison of these different structures the way that we've explained them here in words and how you can see them visually on your x-rays. Okay, so this is the other oblique. Once again, most places you're only going to do one of these. You're going to either do the Mortise or the 45. Just depends on protocol. All right, so this one, you're going to rotate the foot 45 degrees. All right, I want you to remember that this is a joint space, the ankle here. So we want to make sure that the lower limb makes that rotation to rotate the full ankle 45 degrees. We don't want to get into the habit of leaving the legs straight and then having them turn their foot in, because that's not going to turn those malleoli, because those malleoli are part of the tib fib, not just the foot, right? They're not part of the foot, they're part of the tib fib. So the lower leg needs to make the rotation in these obliques. So 45-degree medial rotation, big toe rotating in towards the body medially. Medial rotation, it is an AP projection on the oblique positions. Notice the dorsiflexion of the foot. They mention that they don't say 90 degrees. They don't want it dorsiflex vertical from the IR. You know why? Because if we do that, then those metatarsals are going to superimpose the tarsals that we're trying to see, right? This is for the ankle joint, and the tarsals. And we don't want to pull those toes up and get phalanges and metatarsals in our x-ray. 45-degree oblique ankle. All right, we can see the differences already. You can, one thing you can look at is where those metatarsals are going. See how far they're going medially. They're rotating medially inward toward the tib fib, right? I mean, toward the tibia, I'm sorry, medially towards tibia. All right, but we're seeing distance here between the lateral malleolus and the talus on the lateral side, but over here, the medial malleolus is getting really close to that talus and maybe superimposing into the talus on the medial side, because we're turning the foot pretty far medial, right? So it only makes sense that those medial structures are going to start to superimpose over each other, where the lateral structure is going to kind of spread out and be separated from one another. So it says here that the lateral malleolus, let's go ahead and put it in red here, the lateral malleolus and the talus, no or very little superimposition on the lateral side, but some more superimposition, slight superimposition on the medial side here at the medial malleolus of the tibia. And we're talking about superimposition on the talus itself. So now let's look at the lateral ankle. All right, center ray is to the medial malleolus in this position. We want to include more tib fib in this image than we did in our lateral calcaneus. And I only say that because I don't want you to confuse the lateral calcaneus with the lateral ankle if you're shown pictures of a person in position for one of those x-rays. So be very aware of the center ray placement. For the calcaneus, the center ray placement was inferior to the malleolus. On the lateral ankle position, the center ray is right on the malleolus, the medial malleolus, right? So I want to make sure that you don't confuse the calcaneus position with the lateral ankle position. All right, we're going to see more tib fib in this image for sure, where our center or collimation won't be as tight. We'll include the tib fib in this image. Now, I have to show you this alternate position here. This is not the routine way that you would do a lateral ankle. It's not recommended. It is a lateral medial projection. I just need to show you that it's possible. It could be patient condition that caused us to do that lateral ankle in that position, but it is not the way that you want to do it, and it is not the way that you would do it routinely. Our routine lateral ankle position is definitely the medial lateral projection, lateral ankle position. And here we see a beautiful lateral position of the ankle. Beautiful subtalar joint showing up here. That subtalar joint here. We can see the navicular articulating with the talus here, the cuboid articulating with the calcaneus here. We can see the calcaneus in profile, the fibula superimposed over the posterior half of the tibia. We can see a little bit of the metatarsals here. We want to include part of the metatarsals. All right, we want at least 1/3 of the tib fib in this image. All right, so very specific about no rotation demonstrated by what's happening at the tib fib. Right, that lateral malleolus superimposed over the posterior half of the tibia, right back here. All right, that's what we're going to look for. Tibiotalar joint open. Tibiotalar joint is that talar dome, right? Look for the talar dome there, and that space, that joint space between the tibia and the talus here. Okay, we say that the calcaneus is in profile, the talus is in profile, right, because it's in a true lateral position with no rotation. All right, the Potts fracture is a specific type of ankle fracture that involves the tibia and the fibula. It happens when there's an excessive inward or outward twisting force on the ankle joint, and that leads to the fracture of the tib fib. Okay, stress ankle images are positions that are ordered to assess a tear to the ligaments that connect the tibia and the fibula bones together. It's called a syndesmotic sprain. So we'll do what they call inversion and eversion stress ankle views to assess for a syndesmotic sprain. All right, so the first picture here is the inversion where the toes are, the foot is being forced medially, internally. It's called inversion of the foot. And then eversion is where they take the foot and they stress it laterally away from the body, eversion stress. Notice that somebody's actually holding this person has a leaded glove on. These positions are done with the stress being placed on the ankle during the exposure. So there is a someone in there holding the foot and stressing that ankle inversion stress, take an x-ray, and then do eversion stress and take another x-ray. But the person is holding the foot and putting the stress on the ankle during the exposure. Right, and these are two images, one showing the inversion, and I've inset the picture of the foot being inverted, and then the eversion position right next to it, so that you can identify that, find your tib fib, right? Find the fibula. The fibula is on the lateral side of the foot. If the foot is going away from the fibula, then it means that it's inversion, going in medially towards the body. If the foot is pointing out towards the fibula, that means it's pointing out, exiting away from the body, eversion towards the lateral fibula there. So that's a way of being able to look at the images by themselves and identify whether you're looking at an inversion or an eversion stress ankle view, which is you'll need to be able to do that. And then you see the big white blobs here are that leaded glove of the person's hand that is holding that ankle in that stress view. So really we're just going to be able to see the distal tib fib, the tibiotalar joint there, and then you'll see the feet going either medially or laterally depending on which stress view you're looking at. So it says here we're looking for the tibiotalar joint, distal tibiofibular joint, and trabeculi on the tibia, and the fibula and the talus. That's for the exposure factors here. I would say really if you want to really narrow it down here, this is really about the our exposure factor. The distal tibiofibular joint is definitely going to be showing us that we've penetrated the part here all the way, and that talus is a big fat bone. So the talus is a good way to judge that penetration of the ankle joint as well. So where those structures are the thickest, the superimposition, the tib fib, and that big fat talus, those are really thick structures that we would need to set the KV high enough to make sure that we penetrate there. Exposure factors such as mass will show us the detail of the trabeculi and that spongy bone. Beautiful cortical margins we can see here in the tib fib. So that's what all of this optimal exposure factor is mentioning. All right, so trauma positions of the ankle. So we have a person who has their leg lying flat on the IR for the AP ankle, easy peasy. Center perpendicular, and that's it. That's all you got to do. But now we got to get a Mortise position. But the patient's leg is laying flat on the IR, and they can't move it for us. So what do? We do another one of those little cross angles. We got a cross angle. It's not as much as we did before for the foot. We looked at the cross angle for the foot, but because the foot position was a 45-degree rotation, we cross-angled that amount, for the foot. Now we're looking for a Mortise ankle. Remember, the Mortise ankle was 15 to 20 degree rotation of the ankle. Therefore, the angulation of the tube, that cross angle of the tube, is just that 15 to 20 degree angle. Notice, once again, it's entering the more lateral side of the foot, exiting the more medial side of the foot. So we do call it a lateral medial, a cross-angled lateral medial trauma oblique Mortise ankle. Center A goes in between the malleoli in these images. Lateral ankle, cross table ankle. Once again, they've put the leg up on a sponge here to ensure that the IR is lower than the body part of interest, so that we don't clip that anatomy that we're looking for on our image. So it's always very important with those cross table horizontal beams that IR is placed lower than the body part, and that we're centering the body part on the IR itself, so that we don't clip any of it. All right, center A is horizontal. This is a lateral medial projection because it's entering on the pinky side, see the pinky toe. It's the lateral side of the foot. All right, so entering the lateral malleolus. It's a lateral medial projection. Cross table lateral ankle. For the tibia, the tib fib routine, it's just long bones, so we're only going to do 2 images. But on these images, it's important that we include both the ankle joint and the knee joint on both of these x-rays. So some anatomy. This image here, this one here, is from an anterior, like we're looking at the tib fib from the anterior, and this is from the posterior of the tib fib. All right, so this is the lateral side of the leg. This is the more medial side of the leg. So let's start. Okay, so number 1 would be the medial condyle of the tibia, medial condyle of the tibia. Number 2 is the where the intercondylar eminences are on the tibia. 7 is the lateral condyle of the tibia. 4 would be the proximal tibiofibular joint. And I've also seen on x-rays, they'll be labeling the apex of the fibula, which also sits right there, just under that little line from the 4, the apex of the fibula, sometimes you may see labeled. So we'll say number 3 is the apex of the fibula. 5 is the shaft of the fibula. 9 is the distal tibiofibular joint. 10 is the medial malleolus. 11 is the tibial plafond. 12 is the lateral malleolus. And 13 and 14 are the facets, the tibial plateau or the tibial facets. So number 13 would be the lateral facet, 14 would be the medial facet. And then in between, you see those little bumps there. Those are the intercondylar eminences of the tibia. Okay, so for the tib fib routine, we're going to use a medial lateral projection, meaning that the lateral side of the leg is going to lay down on the IR. We're going to slightly flex the knee. That helps them to place it in a lateral more comfortably. In some cases, depending on the length of the patient's leg, you can turn the IR so that you go from knee to ankle, corner to corner. So if you notice, the knee, the corner of the IR is here. So the knee is going to start up here at this corner, and then going down here at this corner of the IR, we would include the ankle. So they call this, placing the IR diagonally, or we're placing the leg diagonally along the IR. Then we turn the box to place our center ray down the long axis of the leg. So just be working from corner to corner. So if you do this, you need to make sure you're working corner to corner, that this knee is lined up with the corner, that the ankle is lined up with the corner of the IR. All right, so you're going to go corner to corner, placing the leg diagonally, turning the box so that the center ray goes along the long axis of the leg. If you have somebody with a long leg, you really should increase the OID, I'm so sorry, increase the SID to higher than 40 if you can, so that you can decrease the magnification of the leg and giving you a better chance of including both joints on one image. If you have a patient with a leg that is so long that you cannot get both joints on one image, that's okay. You can get the upper leg on one and then use a smaller IR to get the lateral ankle joint and send both of those images together. That's perfectly fine. Okay, so this is I want to focus on the lateral position. All right, so this is the lateral position here, since we just looked at the lateral position of the tib fib. So on a lateral with true lateral positioning with no rotation, we will see B is the tibial tuberosity and profile criteria. Proximal tibiofibular joint superimposed criteria, no rotation. Criteria for no rotation, the posterior half of the tibia superimposed by the fibula. That tells us that it's in a true lateral with no rotation. Now, to describe that we place the leg parallel to the IR, we would say that the long bones, the tib fib, are shown without foreshortening. All right, now here's the AP tib fib. So once again, they did the corner to corner thing. So you see how the knee is up pointing towards this corner, and then the ankle is down here to this corner. So they just put the leg diagonally on the IR, turn the box so that the center ray is along the long axis. Remember, increase the SID to more than 40 if you can, if they have a long leg and you don't have the light field to both of those joints. So to increase that SID so that you see the light field will catch both of those joints and be projecting those joints on the image receptor. Once again, if you can't get it on one because their legs are too long, that's okay. Get one image and then, use a smaller IR to get either the knee or the ankle joint. Okay, so this is our AP tib fib image. So in this one, we are going to describe an AP position with no rotation by stating that there is the superimposition at the distal tibiofibular joint, right? Just partial superimposition at the distal, partial superimposition at the proximal because those joints articulate. So, there is going to be a bit of superimposition there at the joint space. We want to see those intercondylar eminences centered in the knee joint. We want symmetry of the lateral condyle and medial condyle of the femur. We want symmetry of the lateral condyle and the medial condyle of the tibia. Those are things that we can say that we did an AP, true AP with no rotation of the leg. To say that the leg was placed parallel to the IR, then we're going to say that the tib fib are shown without foreshortening. Let's look at Osgood-Schlatter disease. So in that lateral tib fib position, we were looking at the tibial tuberosity in profile. This is a lateral knee position. The lateral knee position is the best position to demonstrate the Osgood-Schlatter disease. All right, this happens when the patellar tendon inserts at the tibial tuberosity, goes across the patella and inserts into the bicep. So this tendon takes a lot of stress, especially for people that are very athletic and do a lot of running and jumping and basketball and football and soccer, because this tendon takes a lot of stress. And, continued stress on that tendon will put stress on the actual tibial tuberosity. And that's what occurs is you can see in some cases the tibial tuberosity can be torn away from the bone. So it says here that in some children, this repetitive traction on the tubercle or the tibial tuberosity is what they mean, leads to inflammation of the growth plate. The prominence or bump of the tibial tuberosity may become very pronounced, and it's best demonstrated in a lateral knee x-ray. So that's the Osgood-Slater disease. So adaptive trauma positioning of the AP and lateral tib fib. All right, so as you can see on the AP position, the leg is kind of rotated out laterally. You can see the toes are pointing out a little laterally. So because of that, they had to take the tube and bring it over here a little bit and angle into the anterior part of the leg and exit the posterior side of the leg. So it's still an AP projection, even though the leg is rotated. So this is a representation of a trauma AP tib fib position. So they had to bring the tube over so that it would in fact be an anterior posterior projection AP tib fib position. All right, so it's, yes, it is cross-angled a little bit. There's no amount of cross-angulation here because this is not to be an oblique, it's to be an AP. So what we have to do is use our eyeballs and find the front of the patient's leg. You can follow the shin of the leg to find the AP part of the leg, or the anterior part of the leg, and make sure that your central ray enters the shin, the most anterior part of the leg, and then exits the posterior part of the leg. And that's how you make that happen. We're just bringing the equipment to the part to make that image work. On the lateral position, it's a cross table, horizontal beam. Once again, they've raised the leg up on sponges to make sure that the IR is lower than the leg so that they don't clip any of the leg anatomy. As you can see, because of this positioning and they couldn't lift the patient's leg up too much, they do have the IR lower than the leg, but that leg isn't right down the center of the IR. And that happens a lot with trauma. You may not get that perfect tube film alignment that you're used to doing with, a patient that's more ambulatory and able to, lay on the table for us, and turn into lateral positions and stuff. So, I know that you would notice the light field being so low, and that's okay. It's trauma. So that happens with trauma positioning.